Hey, it's Rob Fitzgerald once again. Another quick hit in lab medicine. It's glad to have you tuning in. We're in about the 7th month of the pandemic, and so it's been nice to have Studio U here available at UC San Diego to get some other work done. I had the pleasure of riding my bike in this morning. It's a great ride along the coast. I found that showing up to work all hot and sweaty is a really good way to ensure social distancing. So locked away down here in Studio U and trying to get a few things done. So glad to have you tuning in. We're going to talk about really sort of an extension of our electrolytes lecture, and we're going to focus really on acid-base balance. And really what we're going to be talking about is bicarbonate and the bicarbonate-carbonate buffer. It's our central buffering system, and it really gives us a good view of the acid-base status in circulation. So sort of all the other buffering systems feed into this one, and this is the one that we measure. So reference range of bicarb is 22 to 29, something like that. Newborns have a little bit less. They're renal. They're not able to reabsorb bicarb as well renally. But in about 2 to 6 months, newborns, get about the same reference ranges. What we're going to really focus on today is figuring out, are they acidotic? Are they alkalotic? And is it a primary respiratory problem or is it a primary metabolic problem? And so we do that by measuring either blood gases or blood gases gives you a pH and a PCO2, and from that you can calculate bicarb. Alternatively, you can measure bicarbonate and pH and calculate PCO2. So all of that works through the Henderson-Hasselbalch, which I'm sure has driven you crazy for more than one exam. So we think about it as the respiratory side when we're measuring CO2. So that makes sense. That's what we're inspiring, expiring, primarily expiring. And on the metabolic side, we look at bicarb. And so you get acid-base imbalances by either having too much PCO2 or not enough bicarb. And so we're gonna sort of figure that out. What confused me for a really long time, it was pretty obvious to me what was the base. HCO3 is a base. It's a proton acceptor. But they always kept talking about CO2 as the acid, and I was like, CO2 is not an acid, it's a gas. And it took me a while to figure out what they're really talking about is dissolved CO2. And dissolved CO2 is an acid, and it's an acid because CO2 is sort of a planar molecule. It has partial negative poles that sort of cancel each other out. But when it's dissolved in a molecule of water, you get essentially H2CO3. And H2CO3 is clearly an acid. And so we measure the acid sort of indirectly by measuring dissolved CO2. So thinking about it, that you can become acidotic by two mechanisms. You can either have too much acid or you can have not enough base. And if you have too much acid, then your total CO2 or your PCO2 or your DCO2 is going to be high. If you have not enough base, it's going to be a low bicarb, and in the case of excess CO2, that's going to be respiratory. In the case of not enough base, a decreased bicarb, that's going to be metabolic. On a very similar side, you can become alkalotic by the same two mechanisms, either by having not enough acid, and that's going to be respiratory, or having too much base. And so that would be an excess of bicarb. And we're going to talk about that. There are primary problems in all of your patients, and so that's really the trick, is figuring out what is the primary issue, and once you figure out the primary issue, you can look to see if they're compensating. So very simply, pH 7.35 to 7.45, something like that, is the normal range for a pH. And if you're less than 7.35, you're acidotic, very clearly, and if you're above 7.45, you're alkalotic. And then what you need to figure out is did you become acidotic because of a respiratory problem or because of a metabolic problem? Because clearly the treatment of those patients are going to be very different. So what you do is you look at your CO2 and your bicarb. So your pH, you're less than 7.35, you're acidotic. If your PCO2 is high, so RR is the reference range, if your PCO2 is high, that's a respiratory acidosis. And if that's the primary, that's going to tell you a primary disease process that is a respiratory acidosis. However, if your bicarb is less than the reference range, then that's going to be a metabolic acidosis. Very similarly, on the alkalotic side, if you don't have enough acid, that's a respiratory acidosis. That's a low PCO2. Or if you have too much base, that's a metabolic problem. And so really simple. And if you think of it in these terms, you can actually figure out all of your acid-base problems with your patients. So the other thing to think about is that respiratory disorders are compensated renally, and metabolic disorders are compensated via the lungs. And so what happens is that we're trying to maintain a 20-to-1 ratio of base to acid so that our Henderson-Hasselbalch gives us a pH in the 7.35, 7.45. If you have too much, if you stop breathing and you build up your PCO2, you're going to get a respiratory acidosis, and you're going to compensate for that by increasing the reabsorption of bicarb so that your bicarb goes up and tries to maintain that 20-to-1 ratio. And we'll see a couple of equations of that. So again, this equation has driven you crazy probably many times. It's simply the pH relationship to its pK and the concentrations of bases and acids. And again, the figuring out what is the base and what is the acid was a stumbling block for me for a long time until I figured out, it was always obvious that was the base, but DCO2 confused me because it didn't seem like that was an acid. But when you think about it, that's actually a reflection of a carbonic acid, dissolved CO2. So we're trying to maintain essentially this 20-to-1 ratio of, if your base goes up, then your acid should go up to try to maintain that. So this is really the key part of it is maintaining a 20-to-1 ratio so that our pH will be somewhere in the 7.4 range. So a respiratory acidosis is a primary imbalance is an excess of dissolved CO2. And so you're going to figure that out by a pH that's low, so that's acidotic, and it's acidotic because your PCO2 or your DCO2 is high. It can be caused by prolonged hypoventilation, so CNS depressants do that. Pulmonary diseases where you can't exchange CO2 effectively, cardiac disease, same thing. So again, in a respiratory acidosis, the primary imbalance is in excess DCO2, and lab findings are going to be obviously an increased PCO2, a decreased pH that defines it as a respiratory acidosis. And what's going to happen is you're going to compensate renally. Your PCO2 is high, and so your bicarb is going to be elevated as well to try to maintain that 20-to-1 ratio of bicarb to carbonic acid. Urine pH is typically low because you're trying to excrete the excess acid. In a metabolic alkalosis, the primary imbalance is an excess of bicarb. And so again, bicarb is our metabolic side. Too much bicarb makes you alkalotic, and that happens if you've been throwing up a lot. Cushing's syndrome or excess aldosterone causes a bicarb excess. Those are two reasonably common causes of that. So again, the primary imbalance is an excess of bicarb. And so in the laboratory, you're going to measure that. Your bicarb is going to be high. Your total CO2 is going to be high because your bicarb is the main component of that. Your pH is high. You're alkalotic. That's by definition. And after compensation, you're going to decrease your respiratory rate so that you retain PCO2 to, again, try to maintain a 20-to-1 ratio of bicarb to CO2. pH is going to be trying to normalize, and depending on if you can fully compensate or not, it will either be normalized or a little bit high. So a respiratory alkalosis is not enough acid. So It's a decreased PCO2 or dissolved CO2, and it's caused by increased respiration. So breathing rapidly, you blow off PCO2, and you become alkalotic. So that can happen at high altitudes. That can happen with stimulants. So laboratory findings, the PCO2 is going to be low and an elevated pH, so you're alkalotic. And you got alkalotic because you don't have enough acid. So that's a respiratory alkalosis. After compensation, so you don't have enough PCO2, you're going to excrete bicarb, again, to try to lower your bicarb and maintain that 20-to-1 ratio. So your total CO2 will go down and your pH will try to normalize, but doesn't always do that. A metabolic acidosis is it's acidotic, so your pH is going to be low, and you got there because you don't have enough bicarb. So causes would be a diabetic ketoacidosis, where you have overproduction of acids. That's a very good example of a metabolic acidosis. Renal failure is another one where you can't excrete acids effectively. If you lose a lot of base, diarrhea, you're excreting a bunch of bicarb, or a GI fistula where you're actually leaking out bicarb from your intestines, are also examples of a primary imbalance, of low bicarb and a metabolic acidosis. So our metabolic acidosis, the primary problem is a decrease of CO2, and so lab findings, your bicarb is going to be low. Your total CO2 is going to be low. Again, total CO2 is primarily made up of bicarb. Your pH is low. That defines it as a metabolic acidosis. And so you compensate for that by increasing your rate of respiration, trying to blow off CO2, and again, maintain your 20-to-1 ratio of bicarb to carbonic acid. So that's a quick overview of acid-base status and bicarb, and hopefully that'll be useful to you. There are equations you can actually calculate the compensation and determine if they're fully compensating. If they're not fully compensating, then you have a mixed acid-base balance. But still, there will be a primary problem, and you will be able to figure that out by looking at the pH and the bicarb and PCO2. So thanks for tuning in.